For the WFNR, I am the chair of the Measurement, Assessment and Classification, and I'm a member of the flying faculty. We go with the WFNR around the world, and we do training and everything, and that's part of my part. But the other part is I am chair of the WHO Functioning and Disability Reference Group, and I think that telemedicine is very much in the soul of those working with disability all over the world, and I think technology is really great help. It is something that is allowing people where there is nothing to have something, and people that can bring something to others to give it. And so I think our brain is fantastic. It's the matter of my study, but it is also the engine of our studies. And I am really pleased to present two brains, which belong to two people that are using their brains to help others through technology to improve their lives. So this is what technology does, and this is how we, in this context of telemedicine and telerehabilitation, want to use technology. Technology as a means to do our job at the best of our knowledge, of our intelligence. And this is why I'm really, really pleased to present our next speakers. The first one comes from very far away, but through teletransportation we were able to bring him here. And he's coming from Brisbane, and he's professor. His first degree is in philosophy, which means that he is able to capture the thinking of the world. And then his second is physiotherapist. This means he's able to think that we are our body. So our body is really as much us as our mind. So you bring together the body and the mind. And now you go there and present yourself.
Great, thank you very much for that introduction. While the slides are coming up, I just want to say a big thanks to the organising committee for being able to present to you today. I very, very much enjoyed this conference over the last day and a half. It's been excellent, and looking forward to the next bit. It's a great honour to present here, and I'm talking about rethinking models of care. This section of the conference now, we've moved into the sixth part of the conference, which is all about opportunities and challenges. So we're sort of moving away from experiences, now looking at opportunities and challenges. And this morning I'm going to take a run at those opportunities, some of the awesome opportunities that technology in particular is giving us as rehabilitation scientists. So I want to talk about those opportunities. As I go through, I'll also mention some challenges, and then at the end I want to talk about the implications of that for research. So for those that don't know, that's where Brisbane is on the east coast of Australia. It turns out there's an awful lot of jet lag between Brisbane and Italy, so thank you for those exercises. I definitely needed that to stay awake this morning. If I do fall asleep, someone please drag me off stage and we'll move on to the next one. I will not. This is where I work at the University of Queensland. It's a beautiful campus. Brisbane's a beautiful city. We've got great beaches, so you're now all formally invited to come and visit us there in Australia and come and experience some of this for yourselves. So at the University of Queensland, we have the Centre for Research in Telerehabilitation, which I co-direct with Professor Theodoros, who spoke yesterday, and we also have the Telerehabilitation Clinic. And what we do there is fundamental research around telehealth. So how can we use technology to assess people remotely? And if we use technology to deliver care, do we get the same outcome? So we run clinical trials in that sense. But we also have responsibility for educating our students in digital health, giving them the skills to understand how to use this technology. And through a telehealth clinic, we provide services to the public. The interesting thing about that clinic is it's our students that are delivering care to patients via telerehabilitation to members of the community. And this is how we teach them how to do these things and train the next generation of health practitioners in how to use these technologies to deliver care. So we certainly live in a world now where we have access to an enormous amount of technology that we can leverage to provide rehabilitation care to our clients. And this morning I want to really just focus in on some of these technologies, have a look at where they're going, and have a look at some of the opportunities that they present us as rehabilitation practitioners for impacting the life of our clients. And really, I think these technologies will fundamentally change the way that we interact with our patients on a day-to-day basis, and I want to talk a little bit about that. If we get the technologies right, and if we implement it right, those technologies can certainly help us to address health problems and challenges of our clients, but it does so in a way that can improve efficiency, it can improve access, it can improve quality, and it can also help us to deliver more personalised care and precise care to our clients. So first of all, video conferencing. We've heard a lot of applications, a lot of talks over the last 2 days about video platforms to deliver care to our patients, but we haven't seen too many photos like this anymore. So we've moved away from these big room-based video platforms. And one of the reasons we've moved away from that is that we have better connectivity now. So these are the connectivity rates of internet connectivity in Australia. We're up well close to 90% now of the population of Australia has access to good quality internet connections, and that's quite similar all around the world. Interestingly, people are using connectivity to access healthcare more often now. So that top bar there, you can see it's from 2014, 2015, about 20% of the population have accessed healthcare through technology. That went up to 50% in 16, 17, and is certainly much higher there now as well. So people are more willing to access healthcare services via technology. And people have access to the technology in their home environment where we can deliver this care, where we can do video with clients. So people have the laptops and the tablets that have the capability of doing video consults. So, and it's really important that we're now able to deliver care into the home, which is the best environment often for people to do their rehabilitation in their own home environment with their own supports that they have in the community. So the other thing that's changed is that now that we have this connectivity and this technology in the home, we've been able to build more and more specialised devices and software systems to allow us to access the clients. So we've moved away from general systems to more specialised rehabilitation specific systems. So this is one that's come out of the University of Queensland, which allows us to do things such as measure our patients remotely, whether it's linear distance or angles or parameters of speech, and gives us multimedia tools that we can really use to educate our clients and deliver home programs to the clients. And we've seen many examples of these sorts of platforms over the last few days. So we've moved from generalist systems to more rehab-specific software applications over the years. We've also moved from specific equipment, such as those big room-based systems, to more generalist equipment, so equipment that people already have access to in the home. And this is a bit of a sweet spot then as to where we are now in being able to deliver care. So we've got systems that are designed for rehab that work on devices that everyone has in their pocket. And so that's a bit of a sweet spot that we have access to us now to deliver care. The other thing, of course, that we know now is that these things work. So we've got lots of systematic reviews out there now published. This is just one that one of my students has done in the area of musculoskeletal care. But you can see on the right here is where the outcomes favour telerehabilitation over the comparison, over the control groups. So we're seeing that these technologies produce outcomes which are not only equivalent to in-person services, but there is a trend often towards increasing outcomes when you use technology to deliver care. And there's lots of these in different areas of practice now that you would have all seen. So let me just go back. So we've got good technology that works, that people have access to with specialised systems. We've got really good evidence that it works. So the question is, why don't we have large-scale adoption? We still don't see this everywhere. We've still got some work to do to really see this permeate our health systems. And so it turns out that it's more complex than just the technology. There's many other factors that have to be considered when you're implementing telehealth into services. And I'm sure Dave Brennan's going to talk to us in the next talk about some of those things. At the University of Queensland, we've been considering this problem a lot as well, and we've come up with this guide, which is a guide about how to implement telehealth innovations in clinical practice. So if you want to take a technology and put it into a health system to deliver care, what are the processes that you need to think about? What are all of the steps that you need to think about in order to get that right, so that the service does what it needs to do, and more importantly, so that it's sustainable and that it lasts into the future, and it doesn't just reside for the time that you've got that initial pot of money perhaps to get it going. But when we go through these processes and when we get the implementation right, the services can be really sustainable. And I want to give you just an example video of a service that we've set up in one of our hospitals that's now fully self-sustainable, it pays for itself, and it's in an area of care which is quite complex as well, complex spinal pain. So I just want to give you this as an example of how these things can be set up well. Hopefully this starts.
Hi Elaine, can you tell me about your spinal condition and how it began?
Oh, when I was about 18, I was in a car accident and got whiplash. Since I've got older, it's, just got worse. And if I hadn't had telehealth, it would have meant a lot of pain to me. Not only just with my neck issue, but travelling to and from, which is a very big issue out here.
The Spinal Physiotherapy Screening Clinic is a service that allows patients with chronic spinal conditions to have an expert assessment and case management by an advanced practice physiotherapist. Being a tertiary hospital, however, most of our patients live outside of the greater Brisbane area, so access to the service can be quite difficult. For the 70% of patients who are recommended for conservative or non-surgical management, using telerehabilitation has allowed us to provide this service directly into their home.
Initially, I was quite sceptical about referring my patients to the telehealth service, so I just wasn't sure if we'd be able to achieve the same clinical outcomes, particularly for those patients referred to physiotherapy, where the treating clinicians can't put their hands on the patient. With the specialised telerehabilitation platform, what we're finding is that we're able to provide quite complex multidisciplinary treatment, particularly for those patients who are unable to access those services locally. Telerehabilitation has really opened up the possibilities to provide very patient-specific functional rehabilitation that we can't provide in a clinic environment. Consequently, I've become very confident in referring many of my patients to the telehealth service.
The treatment I received in telehealth, I believe, was as good as what I could have had in any clinic situation. And being able to do it in the house has been a godsend.
We're now seeing a rapid expansion of telerehabilitation services in terms of number and complexity in both the public and private healthcare sectors. Our research is showing that the assessment and the diagnostics of telehealth is equivalent to traditional in-person services, and the treatment outcomes that you can achieve are not inferior when you deliver treatment via telehealth.
I was a bit nervous to start with because I'm not very computer literate, but with the help of the telehealth staff and so on, they just made it so much easier for me, and I'd recommend it to anybody.
Some of the new developments then in this area of video conferencing that we're certainly working with is, now that people have got their own devices out into the community, they can use that and download software and access care remotely without us ever having seen them in person. But quite often we need to interact with devices at their end as well. So in this case, for example, we do research and work with the cochlear implants that allow people with hearing loss to have hearing. But of course, to interact with those and to provide calibration services to those remotely, we often need software, specific software and equipment at the patient end of the consultation. And that can be the same if you're working with AAC devices or perhaps smart prostheses that you want to change parameters on. One of the things that we're working on is a way of packaging up all of that software environment that we need to interact with those devices and storing those now up into the cloud so that, and we can have profiles set up for all of the different types of devices that we want to interact with on the client end of the consultation. And the way this works then is when we're in a video conference with a client and we decide that we need to interact with one of those devices and perhaps provide some calibration or tweak some settings on it, we can, during the consultation, we can pull one of these packages down from the cloud, which then has the software environment that we need now residing on the patient's computer, and they can plug the equipment directly into the computer on their end. So with these sorts of technologies, we're able to really expand the scope of what we're able to do via video conferencing without ever having to see that client first face-to-face, or without them having to have specific hardware at the client end of the consultation. So this is really opening up what we can do with our clients remotely when we've never seen them before and when they're using their own technology in the home. Another technology then, wearable sensors. I've been a bit surprised that we haven't seen too much over the course of the last day and a half about wearable sensors. I think I only saw the word Fitbit once or twice in slides, but there's a large number of these devices that are commercially available now, and they're very popular. And the information you can get off them is quite extensive. It's not just step counts, but it's things like sleep, an amount of sleep, active minutes during the day. Some of them can even tell you about your positioning, whether you're lying, sitting, and give you outlines of that over the course of the day. This graph shows the projected increase in the uptake of these wearable devices. We're in 2019, which is only the 5th bar from the left there, if you can't read that. So there's a projection for a large increase in the uptake of these devices over the forthcoming years. In Australia, over half of the population actually own one of these devices. Just put your hand up in the audience if you have some sort of tracker on your wrist now. It's quite a few, not quite 50%, but it's certainly increasing. But there's all sorts of variants of these things that are coming out on the market that I want to talk about. These are smart rings. So it's like a Fitbit device or an activity tracker, but now comes in a ring format. So very small, very lightweight, can give you information on heart rate, on active minutes, on sleep, all of those parameters that you would expect off the bigger trackers, now convenient in a ring. It also has Alexa support, so you can ask it to book you a cab or to book a B&B. And it even has security chips built into it, so people use them to open their doors and things like that these days. So lots of different options out there. And I think one of the things we need to do in the rehab space is think about how we can leverage these consumer devices for rehabilitation purposes. So for example, with these rings, let's put one on each hand in a stroke patient. And if you've got one on both hands, now you can have a look at amount of activity in the left arm versus the right arm to start to have a look at, normalising movement between the two. So there's some innovative ways that we can use these very general technologies that are out there and widely up in the community. There's also lots of movement in the smart fabric space, which we haven't heard too much in this conference either. So smart fabrics are garments that you can wear that are smart, and they've got sensors built into it. This one by Athos has EMG sensors built into it, and heart rate breathing sensors built into it. So it can tell you about when your muscles are contracting over the course of a whole day. If you're wearing this shirt the whole day, you know which muscles have contracted when, for how long over the course of the day. So you can see how people are moving when they're out there in the community, and that information can be transmitted back to you as a clinician. Again, for us to know more about what our clients are doing when they're out there in the community. This is one by Enflux. So this one actually has accelerometers woven into the fabric, and they're able to give you real-time movement data. So this has got 10 built-in motion sensors. This video I've taken the sound off, but as the guy on your left moves, we'll see that in real time we can see what his joints are doing, so how he's moving in space. Now these technologies were built for the movie industry, the film industry, where they want to capture the movement of actors to be able to put on an avatar. But imagine, what we can do with rehab using these technologies. Someone in the community wearing this, we know every movement that they've done over the course of the day and how much they're moving, range of motions and so forth. So some really exciting applications in there. This is one that I love. This is a pair of shorts that you wear. It's made for runners, but the shorts can tell you about your cadence and your step length and how much your pelvis is rotating and stride length. And it has a real-time coaching thing, so the shorts can speak to you and tell you about, sort of how you're running. But imagine that perhaps in a stroke patient at home, so put one of these pair of pants on a stroke patient at home, the shorts can tell them about the movement they're doing and can cue them in the fact that they need to take bigger steps with their left leg or whatever the case may be. So again, it's a technology that's been made for a different industry, but in rehab we need to think about how we can use these technologies for rehabilitation. These are only just over $100, so the cost isn't astronomical either, and we need to think about how we can use those. So in terms of sensors, lots of opportunities. They're convenient, they're multifunctional. There's a growing array of sensors. The new watches that have just been released by Garmin now have pulse oximetry built in. So imagine having pulse oximetry data on all of your patients 24 hours a day. We can take use and leverage the fact that there's wide uptake and there's reducing costs. A couple of challenges: how can we use these devices in hybrid tele-rehab interventions? How can we use that information then to personalise care and motivate patients? And I'll talk about that a little bit later. We've seen lots of apps over the course of the last day. These apps are getting smarter, so not only can you use them to prescribe exercises or care or homework for your patients, they now start to do adherence monitoring as well, so we know how much clients are doing in the house. There's other systems. This is one that's come out of UQ, which will take all of that movement data off activity trackers and put it on a dashboard for you as well. Allows you to do video coaching, allows you to do patient-reported outcomes in a very dynamic manner. So you can send simple text messages to the phone, they pop up, that's got a patient-reported outcome, get them to click on that and it goes into their medical record. So lots of different opportunities with the apps. I think the big thing about the apps is that they're becoming more and more specific to rehab as well. So the challenge for us is thinking about how do we integrate apps with other telehealth applications? How do we integrate apps with a video service so that it is nice and comprehensive? And how do we make it talk with our existing systems? So how do we make that information appear directly in a medical record, I think is the next challenge for us in that M-Health. Virtual reality we've certainly seen a lot of, right from these very simple, very cheap virtual reality options. These Google Cardboards cost about $4. You put your own phone in it, and your own phone is the computing device that you use for it, right through to these more immersive systems. And we've certainly seen examples of these immersive systems over the last few days. Things like this, where you're in a virtual environment, you're looking at yourself in a mirror and you're able to give targets for the person to move towards. And of course, this aligns with the principles of rehab very well. You can make it more and more difficult, you can make it progressive, you can make it adaptive to what the clients are doing. Where we're moving in virtual reality though is that there are headsets now which are building in hand tracking into the headset themselves. So rather than having other peripheral devices, now it can be a simple headset that can monitor your hand movements in space as well. So it's taking one complexity of the system away, and some of these devices are now looking at integrating the computer power into the headset as well, so that you don't have to tether it to a computer either. So that makes it simple for deployment. You put one of these, courier it to a client, they take it out of the box, push one button, and all of a sudden they're in a virtual environment with hand tracking is where we're going with that. But even more exciting with that is the concept of augmented reality. And I think this has huge implications for rehab. So augmented reality, you can see the actual environment you're in, but the technology can put digital objects within that environment. So you can be sitting at your own kitchen table, but all of a sudden some blocks appear or a task appears in front of you. You can still interact with your spouse, you can still interact with your normal environment, but now we can put objects in it that we can increase the complexity of the task that we want them to do with those objects. You can also put other objects in like therapists. So imagine you're in your kitchen, you've got digital objects on your kitchen table, you've got a digital me standing next to you, giving you real-time feedback on what we want you to do. So this concept of actually transporting the clinician into the home environment is certainly where we're going. And this isn't too far away. This technology is with us now. So the opportunities in virtual reality, increasing complexity, ability to track, record responses, it's aligned with those principles of rehab, like I said. The challenge is how do we widely distribute and maintain the hardware component of this, because we still have that logistics about how we get information and equipment around the place and who pays for it, of course. But this is the one I'm really excited about. We hear a lot about artificial intelligence. Artificial intelligence is really coming to us from other industries. So the self-driving car industry, for example, you can see in this video clip on the right-hand side, the artificial intelligence is able to pick out what is another car, or what is a tree, or what is a line on the side of the road, or what is a pedestrian. And it's able to use that information to make decisions about navigation. That technology in health, this ability to decide what something is going to have huge impacts in health. So here's a study in dermatology where they're using AI to look at lesions, at skin lesions. And these are sensitivity specificity curves. So you want to have an outcome which is in the highest top right-hand corner of these graphs. The closer you are to the top right-hand corner, the better you've been in diagnosing these lesions. We've got carcinoma on the left and 2 different forms of melanoma on the right. The red dots in these graphs are dermatologists. So the red dots are dermatologists' efforts at diagnosing these lesions. The blue line is the artificial intelligence, the artificial intelligence effort at diagnosing it. Again, you can see in most cases the blue line is closer to that top right-hand corner than the expert dermatologists. So I wouldn't want to be in dermatology school right now because I think the computers are going to take us away. But what does this mean for rehab? So it turns out that you can not just train AI into looking at lesions, but you can train AI so that it knows what a shoulder looks like and what an elbow looks like and what a hand looks like and a hip and a knee and an ankle. And once the computers know what those things look like, you can do things like this, feed it a video of people moving about, and it's able to pick out that shoulder, elbow, wrist, hand, hip, knee, ankle of all of the people all at once as they move around. So have a look at this. So tracking the movement of all of those people in real time just from a standard video clip without any specialist equipment at the patient end. So imagine this in the home with a normal iPad camera, with just a standard camera in the home. The smarts are in the cloud, but now you have the ability to monitor movement of the client all day long in the home environment and know a whole lot more about what your clients are doing out there and how they're recovering. And this video clip I love, it brings it all together. So I'm going to explain a few things and then I'll play it. In the middle, you're going to see a video conference between a practitioner and a client. The artificial intelligence is going to be looking at the image of the lady, making decisions about whether she's confused or happy or whether she's understood the question or not, and giving information to you about that. It's going to be listening to the conversation and making a diagnosis, which is in the middle of that down the bottom. So the middle bottom of the screen is its best guess at a diagnosis. In the middle of the screen, it's going to be prompting the clinician as to what the next best question should be to the client in order to differentially diagnose one thing or the other. So it's saying you should ask them this question. It's then going to hear when you've asked that question and then move on to the next question. On the right-hand side of the screen, it'll be transcribing everything that's said into the medical record in real time. The top right corner, it'll be adding stuff in clinical codes. On the left bottom side, it's integrating information from sensors, such as heart rate monitors from the client at the remote end, and then it's updating past medical history in the top left. Just have a look at this and think about, sort of what's happening here as we combine video conferencing with artificial intelligence and sensors in a rehab sense.
Hi, nice to meet you too.
So I can see you've completed our AI assessment, and from this, can I confirm that you've been having dizziness for a few months now, with some hearing loss and also some ringing in your ears?
Yeah, that's right.
Okay, you look quite comfortable at the moment. So does the dizziness come and go?
Yeah, I don't have it at the moment.
Okay. And when you do get the dizziness, how long do the symptoms last?
A few hours at a time, I'd say, probably. Yeah.
Okay. And does changing the position of your head bring on the dizziness? Sorry, what I mean to say is, do you get dizzy, for example, when you turn your head to look to one side, or when you turn over in bed?
Oh, okay. No.
Have you felt sick or vomited when you get the dizziness?
No.
And is there anything else you wanted to tell me about your symptoms? For example, have you had any headache, any weakness, any numbness at all?
No.
Okay.
Okay, that goes on for quite some time, so I'll miss that. But that's sort of putting it all together and telling you where we're going with artificial intelligence and how that may impact us as clinicians and how we practice and integrate with our clients. And you can see there's many advantages of that over not using technology, so this will change practice. So rapid development driven by other industries that we can then leverage in a health sense. No additional need for equipment at the patient location, which is a really nice part of artificial intelligence, and it may assist in identifying flagging progression. So we do need large data sets to train these systems specifically to rehab, but I think the challenge for us is how we can use these technologies to better distribute care and to better personalise care for our clients. So what do these technology means then for models of care? So what does it mean for how we interact with our clients? All of these technologies give us various things. They give us more information about our patient in an automated way. So using some of those sensor technologies that I've talked about, artificial intelligence, we know more about the state of our clients as they're out there in their own homes in the community. We know how much they're moving, we know whether they're doing their exercise, we know the fidelity of the exercises they're doing, we know their dosage rates, for example, the intensity of treatments. We also have more control over things like intensity, duration and frequency of appointments. So because the patient doesn't have to travel and sort of experience all that inconvenience, we can see our patients more frequently if that's required. Rather than one hour appointment per week, perhaps in an outpatient clinic, we can see that client every day for 5 minutes and do rapid progression or make sure that they're on track with their exercises. Because of those things, we can personalise care more. We know what they're doing, we can more rapidly personalise the things that we need them to do for their rehab. Of course, it gives us greater access to the patient, and it can lead to greater patient compliance and motivation as well. So with all of those things, that should change the nature of how we interact with our clients. Because of all of those things, we shouldn't just be trying to replicate what we do in a face-to-face environment via technology. And I think sometimes we fall into that trap. We do our randomised controlled trials, we try and take the face-to-face treatment and do that exact treatment online and replicate it. But we need to be thinking about how we can actually leverage these things to deliver better care to our clients out there in the community. And I want to give you one example of how we're doing that. This is in a paediatric population, children with cystic fibrosis. So what we're doing is using activity monitors to see what they're doing in the community, how much sleep they're getting, how much movement they're doing, how much exercise they're doing. We're sending patient-reported outcomes to their mobile phone, asking them questions about symptomatology. We're also getting their parents to feed information into that. They're doing things like remote spirometry with the little devices that we can put on their phone. All of that information then we're integrating, and we're using artificial intelligence to have a look at that and to predict which children are likely to be doing okay and which children are likely to be deteriorating their condition out into the community. So it's looking at things like if sleep's dropping off a little bit, maybe that's because they're up all night coughing, so maybe that's a symptom of them getting worse. And when you combine that with information on exercise and on movement and on heart rate and on all of those parameters, it gives us the ability to generate a risk score about whether this child is likely deteriorating and will end up in hospital if something's not done about this. We use that information to give to a dashboard to clinicians who can then make a decision about whether they need to intervene. So maybe it's a telehealth intervention, maybe they pull the patient in face-to-face, give them a tune-up session, or maybe they alter their parameters on some of the exercise prescription. The other thing we're doing then is taking all of that information we know about the client and putting that into a serious game that the child can have on their phone, so that relevant parameters that we measure of them become currencies in the game. So maybe it's the number of active minutes you've done in the day is the number of dollars you get in the game to spend on certain objects in the game. And we're using things like cooperation in the game. So we're building teams of children around the country. So you've got a red team and a blue team competing against each other. And once you've got a team environment, where what we see is kids often encourage other kids to do their exercises and to do the things that they should be doing because that team wants to beat the other team at whatever they're doing in the game. So you can see how we can use information not just to inform decision making, but to motivate clients as well. And this then means that we don't have to get a child in regularly at every 3-month interval as common practice was. We can now have a look at how they are and only intervene if we need to intervene with them. So we're going from a model of care which is routine, which is inefficient, which is based on episodic episodes, which is reactive, to being able to go to a model of care which is really responsive to how the client's tracking in the community. It's needs-based, it's really efficient because you're only giving care to the children who need care, and it has a preventative focus. It's about stopping them from deteriorating and presenting to hospital. So, as I said at the start, we've now got lots of technologies. If we use that technology right, we can address the problems of our clients, but we can do so in these ways. We can do so in a more cost-effective way, in a more personalised way, in a way that has higher quality. So my last sort of thing I wanted just to say is, what's the impact of that on research? And I briefly mentioned this as I was going through. A lot of the randomised controlled trials that we have seen in our space have been non-inferiority randomised controlled trials. So we try and take what we do face-to-face, we replicate it, and we want to make sure that the outcomes aren't worse than what we do face-to-face. I think now we're at a stage, though, that we've got to change that mindset, and because of all of these opportunities we get with this technology and the information that we've got to get with this technology, we've got to start thinking that we can actually do a far better job than the existing inpatient service. And I think from a research perspective, we've got to start powering our studies and doing study methodologies that look at, you know what, can we actually get better patient outcomes when we leverage all of these opportunities that we have with these technologies. And that's where I think we need to move in the research space. I think that's it. That's all I wanted to say. Thanks.
Thank you very much. Stay there because people might wish to do questions to you. And I think that your presentation gave up the opportunity to have at least 2 questions from the audience. And I give the floor to one and to, okay, please. So that question first and then you.
It's Anwar Subramanian. I just wanted, well, fascinating talk. Thanks a lot. With regards to the point you made when you were speaking about the children, and you said that you gather all this information and use artificial intelligence to inform what you're going to do afterwards. Can you tell us how you use artificial intelligence? Is it it will obviously be on a one-to-one level as opposed to, and how do you do that in practice?
So what we're really looking at over a longitudinal study, did I turn that off somehow? Like, hold it. There we go. There we go. Great. With what we're doing in that particular study is over a longitudinal period. We're using that machine learning to have a look at which children do actually present to hospital, and then working back to try and figure out what the factors are, the unique combination of factors that result in hospitalisation. And when we've got enough children through the study, the machine learning will be able to refine its algorithms about if you see this parameter matched with this one, and this one, the chances are higher that that child is going to present to hospital. So it's a constant learning process where the machines are learning about which combination of factors ultimately result in hospitalisation. And once we understand those factors better, we can start then generating risk scores saying this child's probability of presenting to hospital is higher because of these things. So it's over a longitudinal period.
So thank you very much. I know you got a lot of gadgets and you have shown us. what I'm interested in is that is some of your gadgets are able to actually tell the patients that what exercises you are doing is correct or not correct, and can, once a exercise program is being fed on a computer and on the monitor watch, can this be constant guide to him to correct him? I think if that comes into the play, that will be something which will be really helping the patients through your gadgets and through the telerehabilitation. So can you tell me where you have reached now? Well, obviously you must be working on that.
Yes.
So since that you got the
There's
knickers
certainly-
and t-shirt, everything, yeah.
There's certainly some technologies, and we've seen them presented here about systems that use the Connect to watch the patient do their exercise in the home, and it knows about what they're doing, so it's able to give them real-time feedback about whether they're doing things right or wrong, or they need to lift their leg higher or lower. So there's certainly technologies that are available out there now using technology like the Connect. I think artificial intelligence gives us that next level, though, that without the sensors at home, just with standard video at home, now that the computers will be smart enough to go, you're not moving that leg enough, you need to do that more. And it's able to feed that information through to the practitioner.
You would be ready in next 5 years?
I really think it will be. I really think the technology's there now. It's about making it commercial and making it user-friendly and making it something that we can use. It's exciting.